Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Good day to all attendants in this meeting, wherever you are. First of all, I would like to thank to the organizing committee for inviting us from the Indonesian Radiation Oncology to talk in this very special meeting. With this topic given to me, I hope I can talk about our experience since that actually we have still not yet evaluate the data about this matter. I can just show from our irradiated patient the potential event of fertility in our department. Just to remind us that cancer treatment is not survival of the fetus but should be evidence-based treatment with the goal is not just the response but also quality of life and should be mostly a multidiscipline treatment based on the pathological findings, location and stage of the disease. Again, to remind us, there are three groups of cancer treatment. First is the evidence-based treatment, group of treatment that have already enough data to prove by evidence the efficacy and side effect, for example, surgery, systemic therapy, and radiotherapy, and usually already become the guidelines of the treatment, such as in Indonesia. We have so-called the national and also hospital guidelines for different type of cancer. The second is the novel treatment, group of treatment that have a scientific background but still have not enough data to prove the efficacy and side effect and usually are under the studies. And the third group is the complementary alternative medicine, mostly non-medical treatment. Those has no scientific background at all. There has to be aware that evidence-based treatment does not always match with the patient value or hope. The patient have made a totally different view of what they hope from getting the treatment, how much the suffering can be decreased, how about the fertility condition, how many more time can they live comfortable or survive. Value-based medicine could answer this problem. How we take the best evidence from clinical data, then turn it into the value-based by using the preference of the individual patient, the real person who will have the treatment. Here's the outline of our talk for today. Cancer is known as one of the most deadly diseases in the world, with the estimated increased burden of cancer 2018 to 2040 is in line with the level of Human Development Index. The lowest the Human Development Index is the highest the increased cancer burden. It is 175, 62, and 32% respectively for the low, medium, high, and very high Human Development Index. Here is the mapping of the Human Development Index countries globally. In our region, Asia, cancer incidence and mortality is 49 and 58% respectively, the highest part in the world. Just to remind again, cancer treatment is a multimodality treatment. And radiotherapy is one of the treatment modality in cancer treatment. According to the trusted these two publication, the proportion of cancer patients in whom radiotherapy is indicated during the whole course of the treatment process, according to the best available evidence, was calculated to be 50 to 52.3%, with the most common cancer utilized radiotherapy was breast cancer, 87%. In the lower and middle income countries such as Indonesia, where is the kind of cancer with a high radiotherapy utilization rate, such as breast, cervical, and head and neck cancer, are higher than the global data. So it is estimated that this rate is higher. Due to advancement in medical treatment, cancer long-term survival will continue to increase, as well as value of ability to lead a full reproductive life. So the long-term side effect included the infertility in pediatric and adult productive age cancer survival can be much higher owing to the effect of therapy. And compromise of reproductive function generate high level of distress to patient and their family. On the other hand, evaluation of long-term side effect of radiation therapy and chemotherapy on fertility can be done right now and to understand and the possible option to overcome this issue. Radiotherapy is clinical modality of treatment that use the ionizing irradiation for the treatment of disease, especially 99% for cancer, which is treatment can be given with the electromagnetic beam or different kind of particles as shown in this slide. As an odorless, tasteless, and colorless beam, When it passed to the biological material, will initiate a long interaction process started from the physics, chemistry, and biological reaction that the impact can be happen long life. That's the reason why therapeutic ratio become very important in our field as the state of the art. How can we give a curative dose of irradiation to the target of irradiation with as low as possible impact to the surrounding normal tissue? When ionizing beam is attacked with the biological materials, the ionization process will be happen as a direct effect when it is happen in the DNA, or indirect effect when it is happen in water molecules that will produce the free radicals. Then 53 will be upregulated react by the cells with different levels of the energy damage that will block the cells in the G1 phase as giving time repair process to do maximally. If the repair can be done completely, so the cells are allowed to continue living and doing the proliferation. But if it is not so, the cell will be sent to the programmed cell that's so-called the apoptosis. Please be aware that this will be happen not only in area of target irradiation, but also in the normal tissue surrounding the target. So the stage of the art of radiotherapy, as it is mentioned, is how to achieve a good or perfect therapeutic ratio. How to achieve a good therapeutic ratio? Reduce the toxicity, side effect, and improve the efficacy. As the main goal of milestone technology development in radiotherapy is in line with the development of radiotherapy imaging from the 2D, 3D such as CT MRI. So we also doing the 3D conventional radiotherapy, 3D RT intensity modulated radiotherapy, even tomotherapy. Then in the era of 4D imaging, we also doing 4D adaptive radiotherapy. The main goal of radiodiagnostic is to find the target of irradiation inside the body, and the radiation oncology main purpose is to sculpt the beam, the dose of irradiation exactly in the shape of irradiation target. And nowadays it is 100% positive with the technology called the intensity modulated radiotherapy. Even we have also to face the problem of heterogeneity behavior within the tumor. We got the information from the theranostic imaging like PET-CT findings with the technique so-called the dose painting or simultaneous integrated dose. And also the inter-movement such as a respiration that will move the target of irradiation out of radiation field. We can face that problem with the 4D adaptive radiotherapy or image-guided radiotherapy technique. Against the final goal will be reduce the toxicity and increase the efficacy. This shows how we sculpt the beam of the dose of irradiation using the intensity modulated radiotherapy. On the left picture, we can see that we can shape the irradiation dose. The same color of line is the same irradiation dose based on the target shape and avoid the surrounding normal tissue. Compare with the right picture using the 2D and 3D technique. There are more normal tissue affected by the high dose irradiation that will give the side effect as an impact. More advanced intensity modulated radiotherapy, so-called the rapid arc or VMAT, which the gantry and the collimator are moved around the patient or target. The benefit is the time of irradiation will be faster. That's very important for the precision of irradiation. So-called the tomotherapy or Olinek now is available only one in Cipto Mangunkusumo Hospital. With this machine, we can get an amazing dose distribution for difficult case to treat. For example, we can do the whole brain irradiation for brain met. We can spare the hippocampal or other critical organ that we want to spare, included organ related to infertility. Even we can do the whole cranial irradiation. Whole abdomen irradiation with the sparing of the, for example, one kidney or other critical organ can also be done, as well as we can do the craniospinal irradiation and total body irradiation. And as the message of this all, we can avoid critical structure as needed. This is the machine that we use in our hospital. In the case of target is very close, the organ artery, such as in this case in meningioma, is very close to the other critical organ, we can avoid the hypophyseal area with so-called the stereotactic method, with a very high precision and rapid dose fall off in the surrounding tissue. If the outside of brain, we call it as the stereotactic body radiotherapy, both using a very precise immobilization device, uh, the Lexel G-frame or double mask for the brain, and for the body we use the so-called vacuum blue bag. Again, avoid structure is needed from irradiation is possible right now. This is how we treat the patient. So nowadays, radiotherapy can be given with a very high precision technique, as it is mentioned before, direct to the target, avoid the surrounding normal tissue with the impact, avoid the normal tissue from unnecessary high dose irradiation impact with the intensity modulated radiotherapy technique, especially with the tomotherapy, SRS, SRT, SPRT, and last but not but very important is the proton beam therapy. So basically, by scalping, immobilizing, targeting precisely, and facing the problem of internal movement. So it is more targeted, confirmed, and precise, and can avoid the critical structure. That's radiotherapy nowadays. These are areas of irradiation that could have an impact to fertility later on, the craniospinal total body irradiation as well as the pelvic irradiation. Next, we'll talk about gonadal irradiation. The issue about radiation effect of gonadal has already mentioned long time ago, such as in this review literature from the 1976. In 2005, this journal mentioned the data, the correlation between age, dose to the percentage of ovarian failure if the ovarium is included in the radiation field. For example, in 5 years old patient, we need dose 18 gray compared with 8 gray in 40 years old patient. Possibility of ovarian failure to be happen. In the left table, it is the predictive age of ovarian failure with 95% confidence limit for age of treatment from different age and dose of irradiation. Those data is improved by this 2009 journal. This follow-up model thought to predict the age at which ovarian failure is likely after ovarian irradiation by accounting for age at treatment and radiation dose. The effective sterilizing dose, so-called the ESD, or dose of fractionated irradiation at which ovarian failure occurred immediately after treatment in 97.5% of patients, was found to decrease with increasing age at the treatment. The estimated ESD at birth was 20.3 gray at 10 years, is 18.4 at 20 years, 16.5 and 30 years is 14.3 gray. This model can be used to estimate the age at which premature ovarian failure occurs for individual patients from birth to 50 years at any given dose of radiotherapy. The wide individual variability in ovarian follicular reserve at time of treatment can explain difference in onset of premature ovarian failure between patients treated at similar age. Clinical application of this model would allow a physician to consult a woman in their reproductive potential after radiotherapy. This shows you the effect of ovarian transposition to the function of ovarian preservation. The result is quite promising. Infertility is one of the radiotherapy effects in female reproductive system. Again, it is depend on the dose, age, when irradiated to the reproductive organ is given. Can be as ovarian insufficiency, infertility, and uterine dysfunction. Again, we can see here the older the patient age, the lower dose of irradiation need to impair the ovarium. In males, seems that gonadal organ in male is more sensitive than in female. With the dose of 3 gray could already the possibility make azoospermia. This shows the summary dose-related impact of both ovarium and testicle function. As it is mentioned, in male, the tolerance dose is lower. In males, a dose as low as 1 gray leads to temporary reduction in the number of spermatozoa, while 1.5 to 2 gray leads to temporary sterility. Permanent sterility can be reduced by 5 to 6 gray. In female, radiation dose of 0.65 to 1.5 gray will lead to reduced fertility, and dose greater than 6 gray produce sterility. The sterility dose is lower for older women who have fewer primary oocytes. Now we will talk about hypothalamic pituitary axis. In this review article for pediatric cancer survivor following cranial irradiation showed us that abnormalities include thyroid disease, growth delay, obesity, and abnormal pubertal regulation. Direct injury to the HPA can decrease circulating gonadotropins, FSH, and LH, which are produced by the pituitary gland and regulated by the gonadotropin releasing hormone. Gonadotropin regulation is not as immediate as other hormonal deficiency of the HPA after cranial irradiation, but can be evident within the first 2 years. Pubertal disruption, precox, delayed puberty, lack of pubertal development, primary amenorrhea, and irregular menses are also reported. Here we can see the possible impact reproductive function due to the treated CNS and skull-based tumor. With time, treated can be prepubertal, pubertal, and postpubertal, also treatment-related and risk factor. In the pubertal and postpubertal phase, the treatment-related factor of the hypogonadism can be radiotherapy, chemotherapy, as well as surgery, and also in the pubertal and postpubertal phase, the treatment-related factor of the sexual impaired can be radiotherapy, surgery, as well as psychosocial condition. For the prepubertal, the precocious puberty can be happen due to indicated radiotherapy in that area. Central precocious puberty, the CPP, is a premature stimulating of the hypothalamic gonadotropin releasing hormone. Pulse generator can be triggered by tumor involvement, surgical, and or radiotherapy factor. More commonly in girls following cranial radiotherapy. Now we will talk about how damage the uterine after irradiation depend on the total radiation dose and the site of irradiation. The pubertal uterus is more vulnerable. Dose of irradiation between 14 to 30 gray have been reported to result in uterine dysfunction due to long-term effect of pelvic radiotherapy on the uterine vasculature and development of the uterus. There are several approaches that can do to preserve fertility of cancer patients. How to prevent infertility caused by cancer treatment, both for men and women. First of all, we need to talk in detail with the patient by counseling because the risk can be unpredicted. In terms of radiation, there are a certain dose threshold that we need to be aware of, which can cause infertility risk of almost 100%. However, there are some strategies that we can take, for example, oophoresis, cryopreservation before treatment, and others. There are several guidelines that we can follow for fertility preservation. For example, this is the guidelines for female patients with childhood and young adult cancer. When is it recommended to do oocyte preservation? Here, it is for a patient who will receive ovarian radiotherapy. For male patient, sperm cryopreservation is recommended for patients who will undergo testicular radiotherapy, for example. Again, communication is a key. How to communicate is also important. Don't forget, should we talk separately with the patient and the parents, for example? How is their emotional status? Do they need further supportive support? As this is delicate matter, we should handle it very careful too. Our data from 2020, we have 326 patients under 40 years old, and 57 among them are related in the pelvic and HPA area, which potentially could have a problem in fertility later on. This is the distribution by age with the interval 5 years, and 20% or statistic are pediatric patients. From those 187 patients, gynae 86 are adult female, pelvic non-gynae 27, and HPA 74, with the similar distribution in male and female. And 19% and 59% are pediatric, respectively, in pelvic non-gynae and HPA patient. From those 187 patients potentially to have a problem with fertility later, only one patient done the sperm preservation and 8 oophoresis. So totally is only 5% from all the patients. So what is here the summary? Possibility things happen related to the fertility when we irradiate the patient in the area of HPA and pelvic in pediatric and adult and male and female. So as a conclusion, the increasing number of oncofertility patients due to increasing number of pediatric and adult cancer patients irradiated in HPA and pelvic area, which has been successfully treated and have a long-term disease control. Radiotherapy is one of the major modality in cancer management, and the technology in radiation oncology right now is already in the era of high-precision radiotherapy. Radiotherapy may cause damage to gonad, HPA, and uterine, and the level of damage depend on the patient age during cancer treatment, radiation dose, and technology. Due to low tolerance dose to irradiation, we really need to seriously think to reduce the dose in ORR related to fertility. Is it possible using the high technology modality of irradiation? There are several methods for preservation reproductive fertility, but in our current practice, what we do is ovarian transposition and just started the sperm preservation. Thank you very much for your kind attention.